Myself, Sandhya, ma'am. Ma'am, can I start, ma'am?
Please start, ma.
A 53-year-old female from Harvard, education 12th standard, occupation housewife, socioeconomic status upper lower, para to live to non-tuberctomized, presented with chief
Yeah,
complaints of
please.
bleeding.
Wait. Repeat again. Repeat
A, 50,
again.
a 53-year-old female from
Wait,
Harvard.
wait, 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 wait. There is any gynec patient, male patient coming to the gynec OPD.
No, ma'am.
So please don't mention 53-year-old female. It is mentioned 53-year-old Mrs. So and so. Right?
Okay, okay, ma'am.
Your screen is not visible. It is not very much visible. Why? Uh, okay, tell me. Yeah.
Could you put in screen share? Slideshow, sorry, slideshow.
Okay,
Your
I'll
screen. What is done?
That's okay. Come on. Sandhya, come on. Yeah.
education 12th
Sandhya, you
standard.
can just choose.
Class.
Socioeconomic
The
status upper
slideshow
lower.
mode is down below in the PPT itself.
Right corner, you can see. Yeah, not that one. Three.
Even two
Or
semester
even up
COVID
or
online classes, you people
in,
are not well versed in this, right? Leave alone studying MBBS and
top
final
of
year
the screen,
exam.
you can see slideshow. Sandhya, top of the screen,
Yeah.
there are many options, right? You can see slideshow there.
Wait, I'm trying.
Okay, Sandhya, come. Proceed.
Okay, ma'am.
Yeah.
Chief complaints. Patient
No.
attained
Wait. Go back again. Present as I said.
a 53-year-old female. Sorry, ma'am. A 53-year-old Kasturi from Avadi, education 12th standard, occupation housewife.
Educated to 12 standard. Yeah.
Socioeconomic status upper lower.
What is upper lower? Who said upper lower? What is it? Is there anything upper lower? I think only in the middle class it's upper and lower. Lower there is no upper and lower. Is there anything in the book? Is there anything in the book as upper lower? What is this upper lower? Please, anyone can answer. Yeah, what is it? Sandhya,
Yes, ma'am.
what is upper lower? Please give an explanation. Explain to us what is upper lower. What do you want to say? What do you want to say? Upper lower.
Ma'am,
Sandhya.
in the 14 class, they have upper and middle, ma'am. Class 4,
Yes.
ma'am.
1 second. Upper lower. Okay, fine. Which book is given, Sandhya? Okay, fine. You will give a elaborate things regarding this, right? Proceed, Sandhya. Proceed. Yeah.
Okay, ma'am. Para to live to non-tuberctomized.
Non-tuberctomized. Okay, you can say it as it's not sterilized.
Okay, ma'am.
Yeah.
Chief complaints. Patient attained menopause 2 years ago. Now she presented with bleeding on and off for 4 months.
Wait. You can tell this as menopause for 2 years and now complaints of bleeding on and off for 4 months. So attained 2 years ago. All this is not required. Menopause for the past 2 years and now complaints of bleeding on and off for the so many months, right?
Okay, ma'am.
Okay. Yeah. You know what? Can you define menopause?
Yes, ma'am.
Yeah. Tell me.
Menopause is cessation of ovarian activity. Uh, it's cessation of menstruation for a period of 12 months.
Yeah, you are supposed to start. The diagnosis is only retrospective, and any where you say any patient with an amenorrhea of 12 months is called established menopause. So any bleeding after established menopause, you consider it as postmenopausal bleeding, right?
Yes,
So
ma'am.
you're supposed to start with the retrospective diagnosis. Why it is a retrospective diagnosis? Because why it is called retrospective diagnosis? Only after 12 months of amenorrhea, we will say that she has attained menopause. Okay? Not
Okay,
when
ma'am.
2 or 3 years. Okay? And the age, uh, any person above 40, any person above 40 who has established menopause. What is the meaning of established menopause? Who is a period of amenorrhea for 12 months, and then she has some complaints of bleeding. We call that as postmenopausal bleeding. Okay.
Okay, ma'am.
So, you're sure. What is that climacteric? What is
Ma'am,
climacteric? What is climacteric phase? What is
ma'am,
climacteric phase, Sandhya?
I don't know that, ma'am.
You're supposed to know when you're presenting a menopause. So, what you said for menopausal, decreasing ovarian activity, that is 2 to 3 years before menopause and 2 to 5 years after amenorrhea. You understood? What is climacteric? What is climacteric? It is cessation of ovarian activity 2 to 3 years before menopause and 2 to 5 years following menopause. Okay?
Okay, ma'am.
Yeah, fine. Come, come. Yeah,
History of presenting illness. The patient was apparently well before 4 months. She spontaneously noticed bleeding per vaginum. It was initially spotting per vagina 4 months back, and where she used one pad per day lasted for 2 to 3 days. Later, patient noticed gradual increase in quantity and duration of bleeding per vagina in successive months, where she used 4 pads per day and bleeding for 5 to 6 days. No history of passage of clots, not associated with pain abdomen,
yeah.
discharge per
Wait,
vagina.
wait, wait, Sandhya.
Yes,
When you get like postmenopausal bleeding with passage of clot, where do you get? You are telling a negative history. You are supposed to substantiate. Why did you say the negative history?
okay, ma'am.
Which are the condition where you get clots? If there's going to be any growth, okay, or if there's going to be any cervical proliferating growth, or it can be endometrial growth, where you have clots and things. When you have polyp, it will be a intermittent menstrual bleeding. That's one. It will be 1 day it will be there, 3 days it will not be there. It will not be a continuous thing. Okay. So no issue of passage of clots. Next, what you are telling us, not associated with pain abdomen. What is the cause for postmenopausal bleeding associated with pain abdomen? Tell me.
Yes, ma'am.
Something?
Ma'am, in lower abdominal pain, it may be due to a PID or ovarian cyst.
Hmm. Then
Or,
ovarian cyst present as a postmenopausal bleeding. Very rare. It may, but it is a very rare condition. Okay. Which
okay, ma'am.
ovarian tumor will present as postmenopausal bleeding? Ovarian tumor present as postmenopausal bleeding. Your sex cord stromal cell tumors, your granulosa, theca cell, and things like that. Ovarian tumor presenting as postmenopausal bleeding. Why? Why so? Your granulosa and theca cell tumors. Anyone can answer, not only the presenter. Because it's all estrogen secreting tumors. So you will have The patient, suppose it's excort stromal cell tumor, granular cell tumor, puberty, they will present as pubertal menorrhagia. Recent age group, they will present as intermenstrual bleeding and abnormal AUB. When it occurs in the menopause age, they'll present as postmenopausal bleeding because the tumor itself is secreting estrogen. It's a granular cell tumor. Yeah, come next.
Discharge per
Then,
vagina.
yeah, which postmenopausal bleeding patient will present with discharge also?
Next, mass descending per vagina.
Wait, I'm asking a question. Which postmenopausal condition will present with the discharge also?
Cancer cervix, ma'am.
Very good. Cancer cervix because of profuse discharge and foul smelling discharge you can get. Yeah, then.
Next, blood stain discharge is seen in
You said mass descending PV. Mass descending PV எப்ப postmenopausal bleeding are present பண்ணு.
ma'am, it
When
is
they
seen
have
in
a decipitous ulcer. When they have a decipitous ulcer. Okay. They can present as postmenopausal bleeding. You know what is decipitous ulcer? What is decipitous ulcer, ma? Anyone? Anyone? Decubitus ulcer is a thing which occurs in the prolapse because of the prolonged the cervix and the uterus is lying outside the vulva due to congestion. It will present near the cervix. Decubitus ulcer. What do you treat? What is the treatment for decubitus ulcer? You need to reduce the prolapse and keep it inside the vagina. That's it. Yeah. Come.
next mass per abdomen.
Yeah. Will there be a history of mass per abdomen? You said no history of mass per abdomen. Will
Yes,
the
ma'am.
patient no history of mass per abdomen? How can you say? Huh? No history of distension of the abdomen, you can say. Which
Okay, ma'am.
patient will say, and we should imply that she doesn't feel there's any increased mass or something like that. Yeah, then. Hmm.
Sexually inactive for last 5 years.
How old is the patient?
53-year-old, ma'am.
Okay, fine. Then. Hmm.
No history of similar complaints in past. No history of fatigue. No history of palpitations.
Wait,
No
wait,
history.
wait, 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 wait.
Okay.
Fatigue, palpitation, breathlessness. Why do you want to ask no history?
Ma'am,
What is the
anemia, ma'am.
yeah? No features suggestive of anemia. Just go like that. No, no,
Okay.
no, no. ஒரு மூணு no போடுறதுக்கு no features suggestive, no history suggestive of anemia. That's all. Right?
Okay, ma'am.
Then come.
No history of trauma.
Hmm.
No history of hot flushes. No
Ah,
history of loss of appetite, and no history of loss of weight. No history of bleeding tendencies anywhere else in body, and no history of pain and fever.
it's just pain and fever. Wait, wait. Um. Yeah. Okay. Um. Fine. Go ahead.
Okay. And no history of altered bowel and bladder functions. No history of radiation. No history of hormonal replacement therapy. No history of previous investigations for cancer screening.
Oh, no history of any previous investigations for cancer service, cancer screening. Okay. All the cancers you need to say. What are the cancer screening programs available? What we do here? What are the cancer screening programs we are doing here?
And pap smear.
Very good. Then,
We are
what is the other thing?
visual inspection with acetic acid. VIA, ma'am.
Okay. Oh, first, see, cervix, we have pap smear, we have right?
Yes,
Then,
ma'am.
what else? What
HPV.
else? Yes, HPV screening. Then, for you endometrial, you find out the risk patient. Who are the patients for risk for endometrial CA?
At 30
X
years,
syndrome. X syndrome. What is X syndrome? What is syndrome X? Obesity, hypertension, diabetic. Those patients are prone for endometrial CA. Those patients are prone for endometrial CA. Then patients with family history of ovarian tumors should be seen 1 decade before the, if a family வந்து some person is dying of ovarian or diagnosed as ovarian tumor or breast tumor, நீங்க வந்து அந்த மேபி the previous generationனா 1 decade below means your mother, a patient or a mother or sister is diagnosed as breast cancers or uterine cancers at the age of 50 or at the age of 60 na, you should start screening in the next generation வந்து 40 years ல 1 decade below before, sorry, 1 decade before you need to screen. You understood?
yes, ma'am.
Yeah. Then yeah,
Past
fine.
menstrual history. Menarche at 13 years, regular cycles, 5 days, 28 days, 3 pads per day, soaked fully, not associated with clots and abdominal pain, no history of contraceptive usage.
Yeah, menstrual history, you have to ask about the, how was the menopause? Was it stormy? Was it gradual? You need to ask all those things.
Okay, ma'am.
How do you ask that? இந்த history உங்க புக்லயே கொடுத்துருக்கேப்பா.
We ask according to symptoms, ma'am.
Symptoms இல்ல, menopause-na, attain menopause-na, how was the menopause? Was it gradual or stormy? அப்படின்னா என்னன்னா, like last 6 month cycles எப்படி இருந்தது? Periods last 6 month cycles ரெகுலரா வந்ததா? இல்ல ரொம்ப ரொம்ப நிறைய bleed ஆகி அதுக்கப்புறம் drastic-ஆ stop ஆச்சா? Or was it a gradual? Was it a very uneventful? All the 6 cycles were normal and suddenly she didn't get periods for the 2 years. அந்த மாதிரி you need to put a question and ask, right? Yeah, come. What is the significance of contraceptive use, ma? What is the significance of contraceptive?
Ma'am, it is protective against cancers like endometrial cancer.
Look, your it causes hormonal contraceptive can cause adenocarcinoma of the cervix. What? Adenocarcinoma of the cervix. What is the common type of cancer in the cervix? What is the common type of cancer in the cervix? Yeah, anyone can answer. What is the common type of cancer in the cervix? It's a squamous cell carcinoma. What? All the risk factor what we study for the cancer cervix, right? I mean, early marriage, frequent childbearing, multiple sexual partners, all this will cause squamous cell carcinoma. But when you use a hormonal pill, you can get adenocarcinoma. That is 80:20. 80:20. Okay, you got it? Yes?
Yes, ma'am.
Sandhya?
Yes, ma'am. Can I continue, ma'am?
What did I say now?
Ma'am?
What did I say now? Repeat what I told you now. Yes? Sandhya, am I audible?
So, Sandhya, are you there? Hello?
Yes, ma'am.
Yeah.
Please repeat what I said. You want to repeat again?
Ma'am, hormonal contraceptives. Increases adenocarcinoma of cervix.
Any hormonal intake, normal squamous cell carcinoma of the normal 80% of the patients will have squamous cell carcinoma. The risk factors which we say for cancer cervix is all those multiple sexual partners, early age at marriage, and early sexual intercourse, and then frequent childbearing. All those HPV infection, all those will cause squamous cell. Whereas any hormonal intake can cause adenocarcinoma of the cervix. Yes, yeah,
Yes, ma'am.
fine. Where will you get adenocarcinoma? Where will you get squamous cell carcinoma?
Cervix, ma'am.
Ectocervix, ectocervix is squamous cell carcinoma. Endocervix is adenocarcinoma. You're clear? You got it?
Yes, ma'am. Yes.
Yes. Yeah, that's it. Hmm.
And attained menopause
Then,
at 51 years. From 49 years, she had irregular cycles. Then gradually it stopped at 51 years.
good. Then,
Marital history. Married before 25 years, conceived after 1 year, and
Radhana
non-consanguineous family.
married before 25. She was not sure about her marriage age. Was she not sure about her marriage age?
No, ma'am.
Married at 25. Married at 24. What is that? Married before 25.
Sorry, ma'am.
Married.
It's my mistake, ma'am. I wrote
Okay.
it wrong.
Yeah, yeah. Please go ahead.
Obstetric history. Para 1 at 29 years, all trimesters were uneventful. Male baby, birth by 2.5 kg, cried immediately after birth, breastfeed within half an hour, full term vaginal delivery, breastfeed her child for 1.5 years. Now the child is 24 years. Para 2 at 33 years, all trimesters uneventful. Female baby, birth by 2.9 kg, baby cried immediately after birth, breastfed within half an hour, full time vaginal delivery, breastfed for her child for 1.5 years, now 20 years. No antenatal, intrapartum, and postpartum complications. Delivery was in nearby government hospital. Sterilization not done.
Yeah, fine. Hmm.
Past
Then,
history.
go ahead.
A, a known case of diabetes mellitus for 5 years and on regular oral medication. Not a known case of hypertension, thyroid disorders, bronchial asthma, or PCOS.
Hmm.
Family history. No history of breast, ovarian, colorectal, endometrial cancers in family. No history of bleeding disorders. Personal history. On mixed diet, bowel and bladder habits are normal. No sleep disturbances. General examination. Patient is conscious, oriented, moderately built and nourished. Pallor present, no icterus, cyanosis, clubbing, lymphadenopathy. Weight 80 kg, height 155 cm, BMI 33 kg per meter square. Pulse rate 80 per minute, respiratory rate 18 per minute, BP 110 per 70 mmHg. Breast examination normal, spine
You said
examination normal.
Sandhya, Sandhya,
Yes,
you
ma'am.
said BMI is 33. எங்க patient
Yes,
எதுல
ma'am.
போடுவீங்க?
Grade 1 obese, ma'am.
Grade 1. Okay.
Uh, Systemic examination.
Yeah, tell me. Go ahead.
Respiratory system. Normal vesicular breath sounds heard. No added sounds. CVS S1 S2 heard. No murmur. CNS no focal neurological deficit. Abdominal examination.
Yeah.
Inspection. A flat umbilicus in central position, inverted. Skin over abdomen normal. All quadrants move equally with respiration. No mass visible. No dilated veins. No scars. No
One
swellings.
second, Sandhya. Just hold. 1 second. 1 second. 1 second. I really not started. Yeah. Okay. Yeah, tell me. Sandhya, you said start with the inspection.
Yes, ma'am.
You said, what is that? You just go back again. General examination.
Yes, ma'am.
General examination.
From the patient is conscious, oriented, moderately built and nourished, pallor present, no icterus, cyanosis, clubbing or lymphadenopathy, weight 80 kg, height 155 cm, BMI 33 kg per meter square, respiratory rate 18 per minute, pulse rate 80 per minute, BP 110 per 70 mmHg, breast examination normal, spine examination normal, thyroid examination normal.
A case of post-menopausal bleeding where you suspect some genital malignancy, do you commit as no generalized lymphadenopathy?
Yes, ma'am. The patient is obese. Actually, we cannot palpable the lymph nodes.
No, what lymph nodes you are supposed to see, you should say that. Genital malignancy la எந்த lymph nodes பார்க்கணும்?
Supraclavicular.
You should say there is no supraclavicular node.
Okay, ma'am.
Then what else? What are the other nodes you need to see? Genital malignancy la. What are the other nodes? Inguinal nodes. Yes. So either
Yes,
end
ma'am.
you have to come. No supraclavicular nodes or no inguinal nodes. Yeah. Instead of saying generalized lymphadenopathy, are you thinking in terms of any blood hysteresis? No, no. Then
No,
you
ma'am.
to say specifically there is no supraclavicular nodes, no inguinal, palpable inguinal nodes in the groin. Yeah, come.
Systemic examination. RS normal vesicular breath sounds heard, no audit sounds. CVS S1 S2 heard, no murmur. CNS no focal neurological deficit.
Fine. Then
Abdominal examination. Flat umbilicus in central position inverted, skin over abdomen normal, all quadrants move equally with respiration, no mass visible, no dilated veins, no scars, no swelling. Palpation, soft, non-tender, no mass palpable, no organomegaly. Percussion, dullness present in liver and splenic area. Auscultation, normal bowel sounds heard. External genitalia, no local lesions seen. Per vaginal, per rectal speculum examination not done.
okay, I will give you a scenario, Sandhya.
Yes,
You
ma'am.
have to describe this mask. Patient is lean, and the moment patient lies down, the lower abdomen is distended. Imagine there's a mass in the lower abdomen, and describe the mass. Clinically, how will you describe a mass? Come on, come. I'm giving a scenario. It's a lean patient. The moment the lower abdomen is distended. So how will you describe a mass? What are all the points you will describe if you want to describe the mass?
Ma'am, we have to see the site, whether associated with pain or vomiting.
Wait. No, I'm telling you not the symptom. You want to tell about a mass which is there, which looks like a distended lower abdomen. எப்படியெல்லாம் describe பண்ணுவீங்க? இந்த பேஷண்ட்டுக்கே ஒரு மாஸ் இருக்கு.
Location, number, size.
லொகேஷன் எப்படி describe பண்ணுவீங்க? You need to say mass arising from the pelvis up to as your this thing of 24-week size or up 20-week size, right? You're supposed to say mass arising from the pelvis of 24-week size, or the mass is up umbilicus. Okay, you have to say it like that. Then location.
Number.
Number per abdomen you cannot say number of masses. Number of masses எதுல சொல்லுவீங்க? You give me an example. You give me an example. Example number க்கு that will not come here. Then go next.
Size.
என்னம்மா?
Size.
Then அதுக்கப்புறம் arising from the pelvis Apply, you have to say the lateral borders are. I mean, I am able to make out the lateral border, superior border, but not right. Obviously, a mass arising from the pelvis, you cannot delineate the lower border. Which are the condition mass arising from the pelvis, but still you can delineate the lower border. புரியுதா நான் சொல்றது? Anyone? Hello? Ma, please, others also can just respond to what I asked. I want to know whether you're understanding it because you have not seen patients for years. Yes, Sandhya,
Yes, ma'am.
you understand what I'm telling? Any genital, any mass, I mean any gynecological mass, it will arise from the pelvis. You agree with that point?
Yes, ma'am.
Ah.
Yes, ma'am.
When things are arising from the pelvis, we will not be able to make out the lower border. We'll be able to make out only the lateral borders and the superior border. You got it?
Yes, ma'am.
You got my point? Ma, mattavangalum. Yes or no?
Ma'am,
Yes, ma'am.
pedunculated, ma'am.
Huh? Ah,
Pedunculated.
that's what I'm asking you. A mass from the pelvis, but you're able to make out lower border. Na, enna diagnosis you can give? You can. It will be a subserous fibroid, subserous pedunculated fibroid. You understood? Subserous pedunculated fibroid என்ன ஆகும்? அந்த பிடங்கிள் மட்டும் தனியா வந்து ஹோல் மாசம் வந்து மேல இருக்கும். அப்ப you'll be able to see all the borders. You're able to imagine what I'm telling? Or else you do one thing. Subserous pedunculated fibroid YouTubeல போட்டு பாருங்க. But go ahead. Next. Yes. Then. Or else when you people come here in person, we will show you the cases. Right, come. Then,
In external genitalia, no local lesions seen.
what is the external genitalia local lesion you saw for this patient? I mean, you will see for this patient.
Any ulcer or growth.
Then
Um,
there can be some nodules, nodes, deposits can be seen over the external genitalia. Purida, you understood?
yes, ma'am.
Menopausal nodes can be present. You have to look for that. Yeah, then
Next, per vaginal, per rectum examination not done, ma'am.
not that. Very good. Then, what do you want to do for this patient? What do you want to do? ஏதான ஒரு பேஷண்ட் வந்து போஸ்ட் மெனோபாசல் ப்ளீடிங்னு வருதுன்னா என்ன பண்ணுவீங்க? You can evaluate as OP or admit depending upon the condition of the patient. What is the, you will admit and you will start investigating. What is these specific investigations you would like to do for a case of post menopausal bleeding?
Ma'am,
You see, yeah, tell me.
blood glucose, urea creatinine, ma'am.
I told you, I asked, wait, Sandhya, I asked for a specific investigation for a case of postmenopausal bleeding.
Ma'am, first detect any anatomical cause of bleeding. Transvaginal sampling.
First, look at the patient. If she is clinically pale, ask for hemoglobin and PCV. Then, the specific investigations are ultrasound abdomen. Ultrasound abdomen la என்னென்னலாம் பார்க்கணும் postmenopausal bleeding la. What all you will see in a case of postmenopausal bleeding when you subject that person to ultrasound abdomen and pelvis. என்ன பார்ப்பீங்க?
Endometrial thickness. think ma'am got locked out by mistake. She has to join back.
Sandhya, you're present?
Yes, ma'am.
Yeah. Tell me now.
And
Yeah.
on UEG, we can see endometrial thickness.
Yeah. Ultrasound abdomen and pelvis. You look for endometrial thickness. Then, then what else you will see? If it's going to be, if anyone can answer this, anyone else? Yeah. Hello.
Any pelvic tumors?
Any pelvic mass. It can be an ovarian mass, or it can be an endometrial hyperplasia, or it can be an endometrial polyp, or it can be an endocervical growth. Endocervical growth will not be visible outside. It will be shown in the ultrasound as a bulky cervix. In a postmenopausal ஏஜ்ல வந்து எல்லாமே atrophy ஆயிருக்கும். ஆனா இது வந்து endocervical growth இருந்ததுன்னா bulky cervix ஆ இருக்கும். புரியுதா? Then what else you will see in an ultrasound? What else you will see in ultrasound? You have to look for free fluid, ascitic fluid, anything is present. Then what else? You can look for any lymphadenopathy. Significant lymphadenopathy is more than 2 centimeters can be picked up even in the ultrasound. Then any organomegaly, any deposits in the liver. Am I audible, Sandhya?
Yes, ma'am. Yes, ma'am.
Yeah. So all these things you can look at in. I mean, you have to look in the ultrasound abdomen and pelvis. Any mass pressing the urinary. I mean ureter causing hydroureteronephrosis. Like that, you have to rule out everything in the ultrasound abdomen and pelvis. Okay. Then, what is the next level of investigation? What is that we do next?
Transvaginal scan.
Well, Anama? Yeah,
Transvaginal
it is
scan.
generally ultrasound abdomen and pelvis. Either you do it trans abdominal or transvaginal. You have to look for all these things. Understood? Then, then what is the other things you used to do?
Ma'am, CT and MRI to access myometrial invasion or lymph node involvement.
You will do both CT and MRI. என்ன ஆறுது ரேடியாலஜிஸ்ட்லாம் ஏற்கனவே கொரோனால சிடி எடுத்து எடுத்து எல்லாரும் நொந்து போயிருக்காங்க. நீ ஒரு மெலிக்னன்சி ரூல் அவுட் பண்ண ரெண்டுமே எடுத்தா என்ன அர்த்தம்? ஏதாவது ஒண்ணுதான் எடுக்கணும். யூ கான் டூ போத் சிடி எம்ஆர்ஐ போத். ஓகே. வாட் இஸ் த டிஃபரன்ஸ் பிட்வீன் சிடி அண்ட் எம்ஆர்ஐ? சிடி வில் பிக் அப் which is what is better, I mean defined in a CT rather than MRI. Any soft tissue is better image in MRI. Okay. Sandhya,
Yes, ma'am.
you're audible.
Yes, ma'am.
Yeah. Then
Ma'am, then endometrial biopsy.
wait, we have not finished this. Then non invasive எல்லாம் முடிக்கலாம். வேற என்ன? Tumor markers. What is the tumor markers commonly we see? First level எந்த tumor markers பார்ப்போம்? Yeah, CA 125 normal level இது. What is the normal level of CA 125? What is the normal level mass CA 125? Less than 35. Huh? What are the benign conditions where CA 125 is elevated? What are the benign conditions where CA 125 is elevated? What? என்னம்மா? Anyone can answer, ma? Hey, pasangala, what are the benign conditions where they have?
Endometriosis.
Yes, good. Then,
Any abscess?
yeah.
And then
What
fibroids
are
also.
the? Huh?
Fibroids.
Fibroids elevated இருக்காது. மெயினா வந்து you can have elevated levels of CA 125 in endometriosis. Where? What are the other non-gynecological conditions where CA 125 is elevated? Okay.
Breast conditions.
Then CA 125
Small
எந்த
cell
ovarian,
lung carcinoma.
yeah, எந்த ovarian cancers CA 125 will be elevated? எந்த ovarian cancers CA 125 will be elevated? சொல்லுங்கப்பா, எந்த ovarian cancers CA 125 is elevated?
Epithelial tumors, ma'am.
Epithelial, very good. Epithelial tumors. வேற என்ன tumors tumor markers இருக்கு அப்படின்னா?
We have HPG, alpha fetoprotein.
எல்லாத்துக்கும் சொல்லுங்க. எது என்ன?
Alpha
ஸ்பெசிபிக்?
for stromal tumors.
எது? What is stromal tumors? எதுக்கு stromal tumors?
I don't know.
What is it? Endostromal tumor, sir.
Granulosa theca cell tumors, ma'am.
Granulosa theca நான் இப்ப என்ன சொன்னேன்? இதெல்லாம் இருக்கும். Your hormone levels will be more. Estrogen secreting tumors. அது வந்து sex-cord stromal cell tumors. வேற என்ன tumor markers we can see? Commonly beta HCG in choriocarcinoma. Then வேற Dysphenomenon marker என்ன tumor marker? All the different types of ovarian tumors, tumor markers தெரிஞ்சு வச்சிருக்கணும். Please go read and get back to me during my next class. I will ask you. Then after that, what else you will see? What else, ma? Where any investigation? Specific. So you will see if she is clinically anemic, you will go for hemoglobin PCV, then an ultrasound abdomen and pelvis to rule out any pelvic pathology. Then if there is any pelvic mass and things like that, you have to do CA 125. If suppose there is an endometrial hyperplasia, when will you say endometrium is abnormal? What is the normal value of endometrial thickness during, postmenopausal?
Less than 4 mm, ma'am.
Good, less than 4 to 5. So if it is more, if it's more than 5, what will suggest for the patient?
More than 5, we have to
Endometrial
take biopsy.
biopsy.
We need to do sampling of the endometrium. How all we can take endometrial biopsy? What are the different methods to do an endometrial biopsy?
Endometrial aspiration cytology.
What is that called?
By using Karman cannula, we have to
Karmana. Engineer Karmana Butta. No. There are 3 methods to sample an endometrium. One is you do a fractional curettage. Another thing is you do a pipple. That is, pipple is an OP procedure. Fractional curettage is you dilate the cervix and then you take the biopsy samples, for which you can't do it as an OP. You need an anesthesia. Whereas a pipple you can do it as an OP procedure. Another thing is hysteroscopic guided endometrial biopsy, which is 100% foolproof. You see where the endometrium is abnormal or you see some growth and then take the biopsy from that side. These two, whereas your fractional curettage and your pipple, it is a blind procedure. You may miss, you're supposed to take it from the 6 sides, right, in the endometrium. Anterior, posterior, 2 lateral, and then within the cavity and things. So you may miss the site where the abnormal pathology is there, and your sample will take it from a normal place, and there's chances of missing the diagnosis. Whereas your hysteroscopic guided biopsy, it is 100% accurate, and that is considered to be gold standard for your endometrial sampling, right? Understood?
Yes, ma'am.
Yes, understood. Yeah.
Yes, ma'am.
Yes, ma'am.
Then, yeah. Fine. Then, what else you will do?
Next, ma'am, gold standard investigation. Fractional
Yeah.
curettage.
இப்பதானே சொல்லி முடிச்சேன். இப்பதானே சொன்னேன். என்னையா சொன்னேன்? எது கோல்ட் ஸ்டாண்டர்ட் இப்பதான் சொல்றேன். You're able to follow me or not?
Yes, ma'am.
There's at least answer which is the gold standard to take a biopsy of endometrium. Ma, is this is gold standard.
Fractional curettage, ma'am.
இப்பதானே சொன்னேன் fractional curettage பிப்பலும் blind procedure. Hysteroscopic guided. What is hysteroscope? What is hysteroscope? ஹிஸ்டோஸ்கோப்புங்கிறது இப்ப லாப்ரோஸ்கோப் வந்து ஒரு சின்ன கீ ஹோல்ல போட்டு பண்ற மாதிரி, ஹிஸ்டோஸ்கோப் வந்து you just insert inside the cervix and the uterine cavity, visualize the uterine cavity fully, and then take the biopsy. When you visualize, you will know where the abnormalities or where the pathology or where the growth, and you take the biopsy from that side. Whereas in a fractional, it is a blind procedure. You take it from all the four walls. You can miss the site where the mass or pathology is there. So, which is gold standard?
Hysteroscopy.
Guided biopsy. Histoscope guided biopsy is gold standard. This triple and this fractional is not. Maybe there are possibility of missing the abnormal endometrial collection. Yeah. Then, hmm, hmm.
Um,
What are the commonest? Can you tell me some common causes for postmenopausal bleeding?
it can be vaginal cause like vulval carcinoma. Sorry, ma'am. Vaginal causes like senile vaginitis or endometrial polyp, endometrial hyperplasia, atrophic vaginitis, cancer cervix, cancer endometrium.
All genital malignancy, put it as one common cause. How many? What is the percentage of postmenopausal bleeding will turn to be a malignant cause?
10%.
Hey, 10% is general incidence. நான் கேட்கறது எத்தனை postmenopausal bleeding patients will turn out to be a malignant genital malignancies? 40% of the patients who present as postmenopausal bleeding will have a pathology stating that it is cancer. You understood what I'm telling?
Okay, ma'am.
Yes or no?
Yes, ma'am.
So, the remaining 50% will be a benign pathology. What are the common benign pathology? There will be some polyp, or it can be an urethral caruncle, or it can be a decubitus ulcer, or it can be a misplaced IUCD getting retained and foreign body getting retained in the uterus, and it is presenting with the infection and postmenopausal bleeding. Or as you said, senile vaginitis or atrophic endometritis. These are the common things, common benign condition where patient can present with postmenopausal bleeding. Okay? Yes,
Okay.
yes or no?
Yes, ma'am.
Then, hmm, yeah,
Ma'am, these are
I'll
the
ask you, yeah, yeah, tell me, what, yeah, I'll ask you something. Now, a patient is coming in a perimenopause age group. What is perimenopause? What is perimenopause? தெரியுமா தெரியாதா? தெரியாதுன்னா you tell.
no, ma'am.
It is actually, it is actually 3 to 4 years before menopause and 1 year after amenorrhea. I mean, and 1 year after amenorrhea means it's 3 to 4 years before and 1 year after amenorrhea. So a patient is coming with this and asking you, I need to evaluate myself because she must be around 45. What are the investigation you will advise her to do undergo at this perimenopausal age group? What are the investigations? So you said இல்ல அதேதான் pelvic examination, ultrasound, pap smear, mammography, bone density, cardiovascular evaluation, diabetic status. These are the pap smear, and these are the investigation you have to give a patient who comes at the age of 45. Ma சத்தம் வேண்டாம். At the age of 45 uh, for to investigate in a case of perimenopausal age group. You got it?
Yes,
Huh?
ma'am. Yes, ma'am.
But suppose a patient வருது, she comes with saying that or 50 years, okay, and saying that 6 months amenorrhea. எனக்கு வந்து நான் மெனோபாஸ் அட்டன் பண்றேனா இல்ல அந்த அமினோரியா இஸ் டியூ டு மெனோபாஸ் அப்படின்னு தெரியணும் அப்படின்னு கேக்குறாங்க. யூ அண்டர்ஸ்டுட்? நான் என்ன சொன்னேன், மெனோபாஸ் எஸ்டாப்ளிஷ் மெனோபாஸ்னா 12 months of amenorrhea இருக்கணும்னு சொன்னேன். இப்போ சப்போஸ் ஒரு 50 years patient is coming and saying that I'm 6 months amenorrheic, I want to know whether this is due to menopause or something else. You are doing what is that you will do to diagnose that this may be due to menopause? This 6 months amenorrhea at the age of 50 can be due to மெனோபாஸ்னு எப்படி சொல்லுவீங்க? எப்படி சொல்லுவீங்க? What are the tests you will give her? Offer her. தெரியுமா தெரியாது?
No, ma'am.
Yeah. Anyone else, ma? Anyone else? No. So நீ என்ன பண்ணணும்? நார்மலா டு டயக்னோஸ் மெனோபாஸ் யூ கேன் see the hormonal levels. எந்த ஹார்மோன் தெரியுமா? You know which hormone?
Progesterone.
எந்த progesterone எங்க இருந்து செக்ரீட் ஆகுது? Where is the progesterone getting secreted? progesterone எங்க இருந்து செக்ரீட் ஆகுது? சந்தியா எல்லாமே ovary தான். estrogen and progesterone is getting secreted from ovary. Your FSH and LH is getting secreted from the pituitary. So what happened? எந்த ஹார்மோன் பண்ணுனா நமக்கு கரெக்டா தெரியும்? This FSH LH will be elevated because of the cessation of the ovarian activity. Feedback mechanism la FSH and LH elevate ஆயிருக்கும். FHS more than 40 இல்லனா LH வந்து more than normal na, you can say probably this could be due to your menopause. All of you got it? Yes or no?
Yes, ma'am.
So what is that I told Sandhya? Please repeat.
Ma'am, FSH more than 40, LH or more than normal, then it could be menopausal.
எதனால? Reasons behind that? Reason? ovarian activity cease ஆயிடுச்சுல்ல. ஸோ ஈஸ்ட்ரஜனும் ப்ரொஜெஸ்டனும் ஓவரியில இருந்து செக்ரீட் ஆகாது. ஓவரியில இருந்து இது ரெண்டும் செக்ரீட் ஆகலன்னா ஃபீட்பேக்கா அது ரெண்டும் மேல இருக்கிறதெல்லாம் இன்க்ரீஸ் ஆகும். புரியுதா இல்லையாப்பா?
Yes, ma'am.
எஸ் or no?
Yes, ma'am.
You got it? Yeah. So these two hormones you can check and then you can evaluate. இன்னொரு ஒன்று வந்து inhibin B will fall. So inhibin B fall ஆனாலே your FSH level will increase. Okay va? Okay.
Okay, ma'am.
Yeah. Then I'll touch upon the common postmenopausal bleeding க்கு என்ன ட்ரீட்மென்ட்னு I'll just give a brief thing. What is the treatment of CA cervix, ma? When the biopsy is proved to be squamous cell carcinoma, what is the treatment for CA cervix? Radiotherapy. Squamous cell carcinomas are sensitive to radiation, so radiotherapy. Usually you give external RT for 25 sittings, 5 sitting per week, 5 weeks. Okay. And then followed by internal RT if necessary. So this is the treatment for CA cervix. CA endometrium kenna treatment? CA ovary both are laparotomy. Staging laparotomy for CA ovary. Okay. Yeah. You will have a separate class of genital malignancy where the whoever is dealing that will follow that. Okay. Yeah. So how will you summarize this case? What is the treatment for cervical polyp or endometrial polyp? Sharath, other than the presenter, everyone is muted or something? Why no one is responding? The representative Sharath.
Hello, ma'am.
Yeah, yes, everyone else is muted. Why no one is responding?
Ma'am, then available. Yes, ma'am. I will ask them to respond.
Please respond. What is the treatment for endometrial polyp or cervical polyp?
Some surgical removal, polypectomy.
Polypectomy or cervical polyp, because it will be outside the cervix, so easily we can. If suppose it can be endometrial polyp, you can do it a hysteroscopic guided polypectomy. Okay, because it will not lie outside the cervix, it will be inside the endometrial cavity. So for which you have to do hysteroscopic guided polypectomy or endometrial polyp. Yeah, then yeah, summarize, Sandhya, summarize.
Okay, ma'am. A 53-year-old postmenopausal woman, P2L2, non-tubectomized with chief complaints of bleeding.
Yeah, you are not supposed to, wait, Sandhya, you're not supposed to say P2L2, para 2 line 2.
Okay, ma'am.
Again, start.
A 53-year-old postmenopausal woman, para 2, live 2, non-tubectomized.
Post menopausal women ne sollada. Women only will have post menopause. Yeah, tell me.
With chief complaints of bleeding per vagina since 4 months, which was gradual in onset and progressively increased in duration and quantity, not associated with clots and pain, known history of diabetes mellitus for 5 years, and regular medication, and no family history of carcinoma. On examination, moderate pallor present. Other systemic examination was normal. Diagnosis: a case of postmenopausal bleeding for evaluation.
Okay, fine. So we'll finish with this. Uh, anyway, we have to discuss many more things. Again, like next class, genital malignancies அந்த மாதிரி ஏதாவது வந்தா இல்ல CS cervix present பண்ணும்போது they will discuss, right? Yeah,
Okay.
okay. Yeah, thank you.
Okay, ma'am. Thank you, ma'am.